Gotcha. Perfect.
All right, is that all you needed?
I believe so.
All right, I'll be here if you need me.
Okay, thank you. All right. Is it working? No? No, I don't think so.
It is working. Do you need it in the room? Hear it in the room?
I don't think we probably do. Imagine people can hear me. You don't hear me? Okay. So then we'll just use this for the recording purposes?
Yep.
Okay, very good.
All right.
Well, come on in. All right, so we'll get started. My name's Sam Copeland. I'm one of the 6-year former critical care fellows, so I've got 6 weeks left. I'm excited about that. And we're going to discuss mechanical ventilation. So kind of general backgrounds, some ICU nurses, community nurses, is that correct? All right, so basic understanding of ventilators, a little bit. Okay, and if not, then hopefully we'll have some basic understanding at the end of this. So I stole a lot of this presentation from a former professor that was here. His name was Dr. Al-Alawi, so I'm giving him credit. And so our objectives will be to kind of understand the different modes of ventilation, and then kind of settings that you can get away with even if you really don't know much about what we're doing, until you can get somebody that can come in and kind of help get things set up. And then what will be really important for y'all is to kind of understand the pitfalls and the monitoring and what different things mean, so that when ventilator alarms start going off and nobody's around, you kind of have a general idea of why is it doing that, and is there anything I could do to make this stop. And then kind of we'll talk about some basic ventilation strategies when we talk about the different lung diseases, and we're categorizing those into really the two big components of kind of decreased compliance and then increased compliance. And then in airways disease, decreased or increased resistance of the airways. And then kind of the last little part, touching on just how do we get people off of the ventilator. So starting off with a case, I think a 68-year-old male comes in. He has a known history of COPD, and he's always in the emergency room saying he can't breathe. This time he comes in, he's extremely diaphoretic. He's using accessory muscles. He's got thoracoabdominal disassociation. He's got faint wheezes bilaterally. Heart rate's high, blood pressure's high, respiratory rate's high. So RT gets called and they get a blood gas on him. He's got a pH of 7.15, PCO2 of 70, O2 is 60, and he's on 3 liters per minute by nasal cannula at this point. So what would you do in this situation? Anybody can answer. If not, I'll just wait in a kind of really long time, and we'll all have awkward silence, and then I'll answer for you. All right, going with the second option. So in this way, we can have either non-invasive ventilation, or we can go straight towards invasive mechanical ventilation. One of the things that's getting pushed more and more now is high flow nasal cannula, and there is a benefit to high flow. High flow should not be thought as a primary therapy, though, for hypercapnia. And I think that we can all recognize this is our big problem, is we've got pretty bad hypercapnia. Studies on COPD have shown that non-invasive ventilation is beneficial and can reduce length of stay and save you the need for invasive mechanical ventilation. What we're going to talk about in a second, though, is the contraindications to non-invasive ventilation. And I would say that one of those, and you could could argue the point, but I think most people would say that when you've got that bad of a respiratory acidosis in a patient that is essentially in extremis, that non-invasive ventilation should not be considered. So I think most of us would agree that the ER doc tubes this patient within a few minutes of seeing him in that blood gas. So the types of respiratory support in PPV and mechanical ventilation. So who is suitable to try out non-invasive? So they've got to be able to be alert enough to at least answer some questions. That doesn't mean they can't be a little somnolent. So, you know, they can be tired as long as they're going to arouse and tell you their name and be oriented enough that you think that they're going to be able to protect their airway. And that's the second part of that is can they control their secretions? And so we've all had those patients with just copious secretions. You stick a BiPAP mask on them, all that's going to do is, one, that air is generally really dry, so it's going to start to dry out that pharynx, and then now you've got all those secretions that are trying to come up, trying to get out, and it's got a mask stuck on the face, and then it's going to start to dry those secretions too. And I've seen it where we go in to intubate them finally, and they've got a cask of thick, dried mucus literally covering their vocal cords. So we never really want to get to that point. We want them to be hemodynamically stable, and so if they're hypotensive with 60/40, this is not the patient to try out on non-invasive ventilation. And then I use a pH of 7.2. When we talk about ARDS and invasive mechanical ventilation, we start to talk about permissive hypercapnia and allowing the pH to go down to about 7.15, but I think for non-invasive, 7.2 is a really nice cutoff point. And then kind of any of these other things we'll just say as no other contraindications, and that can just be clinical gestalt, looking at it and going, this patient, they're not going to do well, and that's okay to do too. So we shouldn't be afraid to intubate people. And so a lot of times we'll see that patients were kept on non-invasive ventilation probably a lot longer than they should have because that fear of, oh, are we going to be able to get them off the ventilator? And at that point, we really need to be thinking about best short term and that they're not going to survive unless we get them intubated. So, all right, now moving outside the realm of non-invasive, straight to invasive mechanical ventilation. Whenever we set this up, we really want to be answering these questions of what are our goals, what mode do we think is best, what initial settings do I want to put them on, and then what am I going to do to follow up? Because once we've put a breathing tube in them, they're in the ICU. And now this isn't, we're going to do something and we're going to reevaluate them in the morning. This is, I'm going to do something and 2 hours from now, I'm going to see what that change did and see if I need to make another change. So the big goals are, one, to support ventilation, mechanical ventilation. So ventilation, driving our gas exchange and eliminating of carbon dioxide, and then supporting oxygenation by delivering oxygen. And then also a big one is to decrease the work of breathing. We know from ARDS research and literature that even they're thinking now spontaneous respirations in a patient with early onset ARDS is causing lung injury. And we'll have a big problem with ventilator-induced lung injury, but we're finding more that even outside the ventilator, spontaneously breathing patients with an extreme work of breathing are probably causing some degree of damage to their lungs. Variables. So the method or the mode of ventilation will depend on these three variables. And so you have a trigger variable, a limit variable, and a cycle variable. And depending upon what mode you choose, you can have different of these variables set, either by pressure, flow, time, volume. And so we're going to go a little bit more into what these variables mean. So a trigger variable is basically a decision on the breath. So what point are you going to initiate a breath. And so you have a time triggered, in which case you have this mandatory breath given by a set rate of time. So if you set your rate to 12, every 6 seconds, you will get a breath. Hopefully I did that math right. If not, we're going to act like we did. Except I'm recorded, so that didn't work out so well. All right, and then you have flow-triggered breaths, and so there you have changes in flow that cause the breath to initiate. And so essentially, as a patient will inhale, the ventilator senses a change in flow, and it triggers this breath. And then the other end of that is you have a pressure-triggered breath, and this is generally the same thing. A patient will start to inhale. There is a decrease in pressure caused by the pull down of the diaphragm, and that negative pressure generates a triggered breath. Then we have the limit variables, and so basically this is what limits you set during the inspiratory phase of that breath. And so you have flow limited, and that the ventilator is not going to generate flow greater than that set. And so in this case, we'll talk about COPD patients. They need higher flow rates because of the airways, and so you may have them set at 75 liters per minute on their flow. Other patients you may set closer to 60 liters per minute, and so that's kind of what the ventilator will allow flow to occur at. Pressure limited variables, so the ventilator is not going to generate a pressure greater. So this would be basically pressure ventilation or pressure AC mode, or pressure control is the other name. So you set a pressure of 30 centimeters of water, and that's what you get. It's not going to generate higher than that. And then the volume limited, I think we're all the most familiar with, and this is you set a volume, and the ventilator won't generate a volume greater than that. So you set it for 450. Then you have your cycling variables. So when it ends inspiration and then starts expiration. So this is your transition phase, and so you'll call that cycling off. You have time cycle where you set the inspiratory time. This would be something you would see on pressure control. You would set your inspiratory time to 1.2 seconds, something like that. Flow cycled, this is not going to be seen a lot except really in pressure support, which is more of just kind of a help rather than a full ventilator support. And then with that thing, what you do is you'll set the expiration to occur. Basically, the ventilator will cut off flow after the flow falls below a preset rate that you determine, whether that's 70% of peak flow or 30% of peak flow. It then gets down and cycles off. Pressure cycled, so peak inspiratory pressure gets achieved. This is something we really don't see a whole lot. You can start to see some of these when you get into pretty advanced modes of ventilation, but not something that you're going to see in your standard mode. And then volume cycled, once that target volume gets achieved, the ventilator will cycle off. And that's just, you have to wait to terminate the breath, or otherwise it will just continue to give flow or give air. All right, so types of breaths, 3 big ones. Mandatory breaths, and so it used to be that the ventilators, back when they really didn't have all this really good technology, were set to the point where you got a breath every 12 seconds, whether you were ready for it or not, or whether you were exhaling or not, the machine would give you a breath. And so that was, and still is, a mandatory breath. And so when we set something like AC mode and we set a rate of 12, the patient is going to get 12 breaths a minute, whether they're awake, asleep, breathing or not. SIMV will do the same thing. So you'll get 12 set breaths, and then the patient can breathe above those 12 fully supported breaths. But those are mandatory breaths that are going to be given. Then you have assisted breaths, and kind of difference between assisted and spontaneous is that assisted breaths are going to be patient-generated but fully supported by the ventilator. And then spontaneous breaths are going to be breaths taken by the patient that likely don't have the full ventilator support. And modes, you'll see this more so in modes like SI and V, where you have a set rate of 12, but the patient is breathing 22. 10 breaths, so 10 above 12, to get to your 22 will be spontaneous breaths that aren't fully supported, and then you vary the level of support you give by adding pressure support. And you can have a pressure support of 0, in which case it's just them breathing. So this is kind of just a graphic that gives us information on what we're used to seeing. Once we talk about our general settings, a lot of the ways that we monitor things are on flow volume curves, so pressure curves, volume curves, and flow curves. And this is pretty standard readout from kind of a total easy to view setting on just what you'll standardly see. So we have our PEEP over here. This is what our ventilator PEEP is set at. Notice over here it's giving you Autopeep, and this will be important because this is intrinsic PEEP that the patient has built into them, and that's PEEP above the PEEP you set. Up to here we have our peak inspiratory pressure, and then we have our plateau pressure. What's really important is we really define our true compliance by plateau pressure minus our PEEP, where our peak inspiratory pressure is more of our dynamic setting. So this is more of our resistive flow. So this is the airways themselves, and here is our compliant flow. And so really this whole amount under the curve will generate the total tidal volume given. This is what you would see in a standard AC or volume control ventilation curve. I know a lot of times ventilators now are just frequently getting set to PRVC, and so you're not going to see this plateau here because you don't have the inspiratory pause. But this is what you would see in a volume control ventilation with peak inspiratory pressure. And then here, you're going to have your inspiratory pause before you finally cycle off. And so when we talk about ARDS and other things, and ventilator-induced lung injuries, we're really looking at the plateau pressure being the important pressure here. And so our peak inspiratory pressures we have to pay attention to, but our plateau pressures are really what is going to drive changes in the ventilator settings. And the number that is the gold number out there right now is plateau pressures less than 30. Do you know from some ARDS research that the lower your plateau pressure, the better, but really, really, really need to get that under 30. Okay, so this is what you're going to walk into otherwise when you get into a ventilator, and you're going to have 3 different curves, and they're always generally laid out in this order. I'm sure there are some ventilators that want to confuse you, but for the most part, you're going to have the top one being your pressure curve. Then you're going to have either your flow or your volume curve, and then below that, you'll have your flow or your volume curve. So these two get switched sometimes. In this case, we got pressure, volume, and flow. I think on the maquette ventilators, it's pressure and then flow and then volume. But they'll always tell you up on the left-hand side what you're dealing with. All right, so I'm going to go back to that one here. So we're going to look at a few things. How can you tell on this if the patient is spontaneously breathing or not? So I know on most of the ventilators you get red or yellow curves, and those will tell you spontaneous versus ventilator given breaths. But here we don't have those little color coordinations for us, so how can you tell? What's one way that you can look at and tell?
Isn't it about to tick down before the inflation?
That's exactly right. So you look at your pressure curve, and here you see this little tick down, and this is a decrease in the pressure, and this is the patient kind of getting the diaphragm going, getting the chest wall starting to work, and reducing pressure initially before any of the flow really starts. And then you get the machine sensing that and delivering the breath. So that is kind of one of the more important things on pressure to look at to see whether you're generating a spontaneous or a machine-delivered breath. And then the other portion that you would look at for that's really important in pressure is your top pressure settings here. So this is going to be, again, either your peak or your plateau pressures, depending upon what your waveforms are looking like. All right, so those are really the things that pressure helps us with, at least in AC mode. And then for volume, we really want to see that our volumes are consistent and that we're not having a drop off or it's not reading that we're missing some of that exhaled tidal volume. So if you were to see a curve go up here and then start to come down, and then right about that point it just drops, it goes straight down and it resets itself without actually coming out and finishing. That can be an indication that the exhaled tidal volume isn't completely there because the ventilator isn't sensing the full return. It gets down to the end and it's cycling off. It has to reset back to a 0 point, and it's just going to forget about the rest of that exhaled volume. And so that could be, maybe you have a cuff leak, maybe you have some problems with your ventilator circuit, or you could potentially have some problems inside of the patient itself. Some of this could be like a bronchopleural fistula. You're going to leak air out. You're not going to get all your exhaled tidal volumes back. So that's kind of where the volume curve itself will be really important to look at and just make sure everything's lining up. And then lastly, in your flow, this one can be really important for one specific thing to look at the bedside, and that is Autopeep. So how does Autopeep manifest in a flow curve? And all it is your flow does not return to your baseline. And so you would see your flow come down, and then right about this point, you would kick into another breath. And so your expiratory flow curve does not come back to 0 point. And so that is potentially a very ominous sign, especially in these obstructive airway patients, because you can induce more and more Autopeep to the point where they'll actually inflate the chest so much that they'll tamponade off their vessels and cause hemodynamic collapse. So that flow curve is really important for looking to make sure that you're getting back to that 0 mark. Okay, so this is SIMV. Without me writing SIMV up at the top, how can you tell it's SIMV? So I'm going to go back real quick and then forward. So what's the big difference? Just in all the curves. These are all uniform and symmetric. These are anything but uniform and symmetric. So which one do you think is the machine-delivered breath? The one on the far right, exactly. Really pretty much looks like that. And then over here is our intermittent, or not intermittent, but the patient-driven spontaneous respirations. Now what synchronized intermittent mandatory ventilation simply means is that you are going to set a rate that the machine is going to give you. In this case, we'll use 12 breaths a minute, which is a pretty standard setting. And if you breathe 30, that means you're going to have 18 breaths that are not supported. The nice part about synchronized is that the machine is going to kind of read this pattern and then try to sync one of those breaths with you. And so that ideally, it's a comfortable mode. That's debated. We won't get into that debate here. If you're in an SICU, this is what you're going to see. If you're in a Medical ICU, you probably won't see this, and that debate will never end, and that's okay. What I would try to say is there is never a wrong mode of ventilation. It depends on comfortability, what you're comfortable with, and ideally you try to tailor it to the patient. But here we see that we have pressure-supported breaths to a certain degree, and so without having a number out here, I can't tell you what the pressure support level is, but these are at least partially supported with some help, with just some pressure that it delivers, but it's not fully supported in that you're going to get a specific volume. All right, pressure control. Now, if we go back to here, we see that we have pressures that kind of go up, nice sloping curve, falls off. Over here, we go up, we hold, and then we cycle off. And so this is kind of the way that you would tell a pressure mode to be a little bit different. And again, back when we go to this volume curve, we kind of go up, nice little hump, camelback kind of thing. Over here, we're going to see more of these flatter curves, and then also flow. You're coming up, quickly going down, going into expiration. And pressure, you've got a really sharp flow up, going down, flow decreasing until you get to a 0 point, and then it exhaled, and kind of seeing a mirror of that curve over there. This is just looking at curves. Most places don't use pressure, so I don't want to focus on that because the majority of ventilators are going to be in volume. I mean, even you go up to our ICU where we're supposed to know what we're doing, 95% of our patients are in volume control or PRVC. So pressure has some pitfalls and limitations, but just focus on kind of the more important higher points for today. And then this is just pressure support. And so patients are spontaneously breathing. If they decide, they get 20 milligrams of morphine and they go to sleep, the ventilator isn't going to deliver anything unless it kicks into a backup mode of ventilation. So there is no ventilator support or full ventilator support. There's no mandatory breath rates. There's no anything. It's just when the patient breathes spontaneously, the ventilator helps by giving support through the tube to the degree that you set. You can set it at 1, you can set it at 5, you can set it at 10, 15, 20. You get to pick how much pressure support you want to give them. And all it does is when they breathe, it delivers pressure. So it senses that change in pressure, and then it delivers the pressure support that you set. And this goes back in when we talk about that flow kickoff curve where you hit a certain point of your max peak flow and it will cycle off. And that's how it determines that. So kind of switching gears and just talking about the initiation, because this is the part that was really hard for me when I was learning about this is, all right, we got to this point, what setting do I want to give? What do I want to do? And so the first and most important thing that you would do is use a familiar mode. And again, 95% of that's going to be AC or PRVC. And so you can't go wrong setting your tidal volume at 8 mils per kilo. It's pretty much a universal setting. And then if you have ARDS, you want to work them down to 6. But your initial settings can be 8. Most patients can feel pretty comfortable on 8 mils per kilo. And then I'm going to hammer in one important point on that. You have 230-pound kilo person. So your tidal volume is going to be about 2 liters, right? That doesn't sound right. So where's the important caveat of this? 8 mils per kilo. And that's ideal body weight. So we always set to ideal body weight. And probably one of the things that stuck with me more than anything was your lungs don't get fat. They always stay the same size, unless you're growing. But we're not kids, so we don't have to worry about that. So, always ideal body weight. It's never wrong to give them 100% oxygen initially. You can always wean that down really quickly once you get the ABG in 30 minutes. So if you're worried, you put it at 100%. And most times when we do this, they're at 100%. And then within 2 hours, you can have them down to 60%, 50%, 40%. And all we're really trying to do is, depending upon our condition, maintain our saturation at 88% or above. In some cases, depending upon if they have coronary disease and other things, you can keep it at 92. You're never wrong to keep it at 92, so that's why we put it in here. But we get pretty comfortable getting down to about 88 now. And then PEEP, you set PEEP, it's really to support oxygenation. So the two ways that you support the oxygen content, the PaO2, is the inspired oxygen content, FiO2, and the PEEP. And so PEEP is essentially positive end expiratory pressure that allows alveolus to stay open during exhalation and kind of stay recruited. A universal PEEP setting is 5. So if you go 8 mils per kilo for your volume, FiO2 of 100% and a PEEP of 5, and then the last thing you have to set is your rate, and 12 is a very reasonable rate, you can ventilate somebody for a few hours while you get help to come and kind of tailor it from there. So those are kind of universal. 95% of the patients we see can be supported with that type of settings for a few hours. Okay, so we set them up. Now how do we want to monitor them? So pretty standard ways. The vitals are always important. You know, if you set them up and their vitals crash out, something's going wrong. So, and we're not talking about the immediate 5 minutes after they get all of the induction anesthetics for intubation. We're talking about an hour or two later, they're still hemodynamically unstable. If they were stable beforehand, something went wrong with the ventilator, so we need to fix that. We look at the SATs, and so the SAT monitor, we always got the probe on, and we want to titrate our oxygen content to that. X-rays, so immediately following the post-intubation X-ray, we can get a lot of information if they haven't had a chest X-ray yet before. And then 30 minutes to an hour after we intubate somebody, we want to be getting an ABG. And that's going to allow us enough time to kind of equilibrate from that experience. And then the last part will be looking at the patient and the ventilator and how they interact. And we're looking for, is there any asynchrony, meaning is the patient struggling against the ventilator? Because ideally we set them up and they do really well. That doesn't always happen. So specific things we look at on the ventilator to kind of assess that asynchrony is inspiratory pressures, expiratory volumes, Autopeep, and then if the thing is just beeping at you from inside the room every 5 seconds, we probably could do something different. So when it comes to alarms, the probably 3 biggest alarms you're going to see are going to be your high peak pressure, your low exhaled tidal volume, or you have a low minute ventilation. And this will kind of come back to things we already touched on a little bit earlier. A little more coffee. So your peak inspiratory pressure, again, is more so your resistance in the airways. Plateau pressure being more reflective of the compliance of the lung. And so you walk in and you have high pressure alarm going off. You've got a peak inspiratory pressure of 65, and you've got a plateau pressure of 20. Where's your problem? Without even looking at the patient. You're just looking at the ventilator, peak inspiratory pressure of 60, plateau pressure of 20. The difference between peak and plateau should be about 5. So you've got a difference in 20 right now. So what can you do? Where's the problem?
Is this in the airway?
It's in the airway. So maybe the patient has copious secretions and they've obstructed the ET tube with those secretions. Maybe they were a heroin overdose and it's been 8 hours and all of a sudden they're awake and now they're biting through the tube. That's your resistance. So that's where you're looking at for high peaks with normal plateau pressures. And then the other scenario is going to be ventilator pressure alarms are going off and you've got a peak pressure of 45 and a plateau pressure of 40. And 30 minutes ago, the intern was putting in a subclavian line. Where's your problem? Pneumothorax. All right. So these are really important things that can be assessed very quickly with the help of ventilator alarms. The other thing that you would see is, this patient just had a massive aspiration. They're hemodynamically unstable, so they get intubated, and immediately their peak and plateau pressures are high. And now you're talking about severe inflammatory pneumonitis developing into ARDS. And so ARDS is all about decreased compliance. Again, plateau pressures being reflective of the compliance. Okay, inspiratory and expiratory ratios. So these are all things that will affect your inspiratory time. And so when you talk about that, you're saying how much tidal volume am I going to give? How fast am I going to give it in the flow rates? And then what type of volume inspiratory waveforms have I given? And so the larger your tidal volume, generally the longer it's going to take you to give that, even if you're really going fast. And so the flow rates really will probably be one of your more important things here. And so just for sake of hopefully easy math, again, mental math is not my strong suit. Let's talk a little bit about flow and how this works. So we have a flow of 60 liters per minute. Okay? Well, what does that mean? It means we're delivering 60 liters over a minute. Our tidal volume is set at 500 mils. So that means we have half a liter tidal volume. So if we're set on a breath rate of 20, how many cycles am I going to have in that 1 minute? So I'm going to have 3 cycles. My then flow rate is at half a liter inspiratory, right? So that is then half a second. And then my other time, 2.5 seconds, is going to be devoted to exhalation. Is everyone follow that? So 60 liters per minute, 20 breaths a minute. So I have a 3-second cycle total. Half a liter is going in every half second, right? 60 liters per minute, 1 liter per second. So half of that goes in half a second, and that leaves me 2.5 seconds on an exhale. So that's where our flows really will adjust. Now, the flow adjusts a little bit, but what if I lower my breath rate from 20 to 8 or 10? Cut that in half. Now I've got 10 breaths, for easy math, so I'm getting a breath every 6 seconds. My flow rate's still set at 60, so I'm giving that 500 mils in half a second, but now I've got 5.5 seconds on an exhale time. And so that's where rate, volume, and flow all will kind of adjust. Now the maquette ventilators, which I think we're phasing out, but we still have a lot of them here, they don't necessarily have a specific flow on it, but flow is set by your inspiratory to expiratory times, and that is set, and you'll see that on the maquettes. And then factors that will lead to inadequate expiratory times. So you'll have incomplete exhalation. So this is all patient ventilator asynchrony. So the patient's trying to exhale. They've finished their breath, but the ventilator is set so that they can't exhale yet. And so they're trying to breathe out, and it's still giving them breath. Or they're trying to exhale, and the mandatory rate is such that it's given a breath again. And so that's more of these obstructive airway problems that we'll see there. And that will lead to breath stacking, and then that leads to Autopeep, and that leads to a lot of problems. Are there questions over that? No? Okay. I don't know why that curve is in there again. Maybe I was going to... I think I was going to maybe talk about that a little bit later. But anyways, we'll just skip through those. We've already talked about those. So let's talk about Autopeep. This goes back to the flow curve. And the flow curve is really where Autopeep can be seen. And it's, as we were talking about earlier, you have your inspiratory, you have your expiratory. Inspiration happens. Go into the expiratory phase. They're trying to breathe out. Oh, ventilator kicks in. This is Autopeep right here. So there. And how does that manifest itself? By high inspiratory pressures, hypotension, decreased oxygenation. So you're probably wondering, how does having too much PEEP, when I've previously told you PEEP is your friend, PEEP gives you higher PaO2s. So how does Autopeep cause decreased oxygenation? And it's simply that you have hyperinflation to the point that you actually start to collapse the pulmonary circulation. You start to collapse any of the vessels intrathoracically to the point where you can get tamponade physiology. And so what will be really scary is, let's say you have a 32-year-old asthmatic patient in status asthmaticus. They get put on the ventilator, and you're seeing these curves. And then about 30 minutes later, their blood pressure's 70 over 30, SaO2's reading 65. What do you do? What's the absolute number one thing you have to do right there?
Would you listen to them and see if they've got some wheezing or
So,
collapse?
it's never wrong to do a physical exam. But you're pretty much just not going to hear anything because they're in status. They're not moving air. Even if they weren't hypotensive, you're just not really going to hear a whole lot because of how clamped down their bronchioles are. But you would disconnect the ventilator. And that's a scary thing to do when they're hypotensive and they're not satting well. But you would disconnect the ventilator. And I do this, and I just count out loud inside the room. Pull the vent off, count to 40. 1 Mississippi, 2 Mississippi. And almost always, by the end of that 40 seconds, oxygen's improved, hypotension's improved, and then you reconnect the ventilator, but you have to then make some changes to the vent. Because if you don't, 30 minutes later, it's going to be happening again. And so the way to correct Autopeep is to let them deflate and then make changes to the vent. Okay, so decrease Autopeep. And this goes back into kind of flow again. So we're looking at ways that we I'm trying to think here. So ways that we will decrease, one, the amount of volume to try to decrease PEEP levels, or intrinsic PEEP levels, and then we want to decrease respiratory rate, and we also can, and this is counterintuitive, increase flow, right? Because what happens when we increase our flow rate? By delivering that breath we want to give faster, we leave more time for exhalation. But remember, when we did our math a few minutes ago, we found that flow rate can help us a little bit. It may change us by a few seconds or half seconds. But respiratory rate is really one of the big things. And so by decreasing that respiratory rate, getting it as low as we can tolerate is probably the best thing you can do. And so if we're really in a bad situation with bad obstructive airways disease, we're going to do all three of these at the same time. One of the things you really got to pay attention to, though, is what's the problem with bad obstructive airways patient? Peak pressures. If I'm trying to deliver that breath over a shorter period of time, I'm only increasing that peak pressure. Right? I'm trying to deliver that full volume in a shorter period of time. Resistance is going to be worse, and my pressure is going to go up. So that's one of the problems with trying to increase your flow. And so you can do that a little bit, but you just have to kind of pay attention to your peak pressures. So your best bet is going to be your respiratory rate. And then sometimes just getting that volume down. You know, you're trying to set them at 500 because they're CO2 70. You may have to take them down to 280, 300, 320, just long enough to keep something going, trying to keep them alive while you then let the airways start to open up. So that's questions over the first part of this. We still have a little bit more on kind of running through some case scenarios and then also liberation of ventilation. But that's kind of short, quick ventilators. Maybe not so quick, 48 minutes, but I can talk a lot apparently. Yes, ma'am.
Can you go over the low minute ventilation?
Low minute? Oh, so low minute ventilation is almost always going to be that either you didn't set up the ventilator properly, you put in 280 tidal volume in a rate of 5, you're going to have a low minute ventilation. The other way that you'll start to see low minute ventilations is that you're going to have incomplete exhale tidal volumes, so it's not registering it. And so it's reading minute ventilation as the respiratory rate times the tidal volume. And so anything that will affect those two parameters will give you low minute ventilations. But if you appropriately set up the ventilator, then your low minute ventilation is probably going to be that you have circuit disconnect or that something outside of the patient has gone wrong. Other questions? Now, the other part where you'll start to see low minute ventilation problems, and again, I didn't really go into it a whole lot, is going to be in pressure control. So you always have things that you set, and then you have your variable. And so in volume control, you set your volume. So what's your variable? Pressure. Pressure control, you set your pressure. So where's your problem going to be? In the volume. Your variable will be in the volume, which is also where it's going to manifest when things go wrong in pressure control ventilation. So you'll set them up appropriately in pressure, and now you had a minute ventilation of, let's say 8 liters a minute, and then now you've got a minute ventilation of 4. Well, what's happened is you've lost half your tidal volumes. So either your resistance has changed to the point where you're not getting your volumes, or your compliance has changed so you're not getting your volumes. But it could be either one of those. And that goes back into, again, you get into the flow curves. Your flow curve tracing will change in pressure, and that's really where you want to find your problem. But that, if you can remember volume control and the problems that get wrong there, you're gonna be fine. All right, other questions? Yes?
Why do you use the APRV setting or the bivent?
So bivent. Bivent is a special little guy, and it's essentially two peeps. So I'm going to go over here and draw really badly, probably. So I use bivent or APRV as a rescue mode for poor oxygenation. And I can almost guarantee you that I can fix hypoxemia with APRV in 98% of patients. And the other two that I can't fix it with APRV need ECMO. So when I've got them set to low tidal volume ventilation strategy, right? So we're talking about ARDS. Right? ARDS is our big, is our big problem with hypoxemia. APRV is really contraindicated in your obstructive airways diseases. So you're really going to be using this for refractory hypoxemia and decreased compliant lung diseases like ARDS. And in this case, you'll get tidal volumes of 380, respiratory rates of 24, PEEP of 22 on AC mode. And my SATs are reading 81%. Not much more I can do there. Okay, I've maximized my vent to the best of my ability. Let's say I've paralyzed them and I've proned them, and they're still not there. If you ask me, that should be the correct workflow. We know low tidal volume ventilation saves lives. We know high PEEP has beneficial outcomes. Paralytics have decreased mortality in ARDS. Prone positioning, decreased mortality in ARDS. So we do all of the things that we have good data on first. We're still hypoxemic. Now, I know this isn't the way it's always done. Everyone practices medicine differently, and we're going to see a lot of APRV here, and that's okay because we're still learning and we're evolving. But the literature has never supported outcomes in APRV, but it also, the only one that has been supported in ARDS is low tidal volume ventilation. So we're refractory, we're hypoxemic, so we go into APRV, and that's when I would use it. And APRV is simply two PEEP settings. All right, we have a high PEEP, we have our low PEEP. And we hold our high PEEP for a period of time, and then we release that PEEP to our low PEEP. We hold that PEEP for a period of time, and we go back up to our high PEEP. We do that again. And you'll hear this called APRV, airway pressure release ventilation. You'll hear it bi-level because we have two pressure levels. And you'll hear it called, what was I thinking of? One more. Inverse ratio ventilation. Inverse ratio ventilation. Even though inverse ratio ventilation is technically its own thing, but you'll hear it called that. So we're going to use high PEEP settings, right? We're already refractory hypoxemia. PEEP improves hypoxemia. So here we'll have P highs of 24 to 30. P lows will generally be either 0 to really I probably wouldn't ever go above 5. And then we're holding these high times for 4 to 6 seconds, somewhere in there. And our release times are about half a second to 0.8 seconds. And what this does is it oxygenates. And it oxygenates by holding such a high pressure for the majority of the time that you recruit lung. And so that's the way it works. It's recruit. So you get good recruitment, and by recruiting lung, you oxygenate otherwise collapsed alveolus. And that's how you improve hypoxemia. The problem is your ventilation occurs very quickly, and so this mode is notorious for getting hypercapnic. So you really have to pay attention to hypercapnia. And this is where we'll see those pHs at 7.15 and be semi-okay with it because we're fighting the oxygen problem. The other big problem is this is pressure mode of ventilation. So what's my variable? Volume. We just said we have ARDS. It's really the only time I ever used this for. What do we know about ARDS? Low tidal volume ventilation saves lives. So I go from a tidal volume of 380 and I put them up to a PI of 30 and a PLO of 0. My sats come up to 99%. We're all high-fiving. Got a tidal volume of 800. And this is where APRV becomes problematic because people forget that we still have to remain at low tidal volume ventilation. And so it's really important to adjust settings to make sure that your tidal volumes are staying where they need to be. So you can get into a lot of trouble in APRV, but we will use it, and it can be used. It's a tool. So I don't want to say we shouldn't be doing it because it is a tool and it's got its use, but it's just a lot of things to be really cautious on. Okay. Did that answer the question, hopefully? I spent a long time answering that if it didn't. All right, any more questions? Nope. All right.
What's the difference on a hi-fi then?
Hi-fi? High frequency? All right. So, no, you're fine. I pretty much will never use high-frequency oscillatory ventilation. And the reason for that is I think if I'm going to have to use a rescue mode, I like APRV more. There was a really nice trial done called the Oscillate trial. Oscillator, right? The oscillator, high frequency, so Oscillate trial. And this was published in the New England Journal. And it was a multi-center trial. And the thing behind it said, you only use the oscillator in patients that you can't oxygenate otherwise. So that's why it doesn't work. So the Oscillate trial said, well, let's put ARDS patients that are early on an oscillator early before it becomes a rescue mode. And so they did that, and it showed no benefit and actually a trend towards harm. With that being said, what it does is it, rather than using tidal volume ventilation, uses extremely small oscillations to move air in almost like a continuous type column, essentially. And so you use amplitude of the oscillations to push those little miniature air cycles, and then you also have the frequency at which you oscillate to push those air cycles around, and it almost kind of just moves in this slow ventilation. In theory, it works great. I mean, you literally take your tidal volume down to 0, and we know high tidal volumes cause lung injury, and so in theory, it should work. And there are some people that are still not convinced on the Oscillate trial that are going to try to do some more research on it, and they'll once again prove that it's not beneficial, but that's just my take on it. The way that you adjust the oscillator is you adjust the amplitude and you adjust the frequency. The amplitude and your mean airway pressures become the way that you oxygenate. And then you then also use ventilation by the amplitude, but then more importantly, the frequency. So if you read what I think my opinion is we don't necessarily do the set up for the oscillation correctly here. I think our protocols are a little off, just my opinion. I think we need to maximize our amplitude, at least in adults. Children is very different. I don't know the first thing about ventilating a kid. But for adults, we should maximize our amplitude. And so we have amplitude maximums of like 90, and then we should maximize the frequency up to the point where our CO2 won't allow us to do it anymore. And then counterintuitive, higher frequency, we should have more ventilation, but counterintuitively, because of the way that we're actually moving this column of air, by decreasing our frequency, we'll actually improve our CO2 output. So we'll get more CO2 elimination by decreasing the frequency. So minimize your variables as much as possible, maximize your amplitude, and then maximize your frequency up to the point where CO2 allows. So if you can't, again, hypercarbia being the problem with oscillation, you want to, if you are not able to do what you need to do with your frequency, you can actually induce a cuff leak so that you can eliminate CO2. And that's kind of the last thing you can do. So you will oxygenate with oscillation. You will. And I've set it up before. I think there's better ways to do it now. But that is really, really advanced ventilators at that point in time. So, other questions? I don't have any schematic or diagram to draw.
So whenever it comes disconnected, you have pretty much always bag them. I heard two different things. One, bag them really quick, or two, hold it and let go.
Yeah, it probably depends on what you're trying to accomplish. So by bagging really quick, you are going to generate pressure. You're hyper expanding them, but you're probably not truly getting effective volumes. And so if you're just trying to get them with their oxygen up, it's probably not a terrible idea. But you can't do that forever. You're going to hyperinflate them. And so you can't go wrong with the bagging of one, get a PEEP valve on your bag. I think that's something you can really do. Get a PEEP valve on the ambu bag and put it up to 20. And then just give a good squeeze. And you want to get, third to half of the bag squeeze in, and then go ahead and give them time to exhale. And everyone is going to squeeze fast because they're crashing if you're bagging, and then the drone's rushing, and you're just going to see every time. It's okay. They'll stabilize out and then put them back on the vent. If they got to the point where you have to bag, though, you're gonna need to fix the ventilator, because the ventilator probably has at least part of the problem with them needing to be bagged. Your settings aren't right. So, and you'll see that a lot, though, right? I mean, we bag up a patient, we put them back on the vent, and we're bagging them up again in 10 minutes because we didn't make any change. So, and sometimes there are no changes you can make, but that's where I don't know that truly makes all that big of a difference. Just get them fixed one way or the other. All right? Sometimes critical care is just doing things, and if it doesn't work, doing something else. Septic shock, we give volume. Doesn't work, we give pressors. That didn't work, we give Lasix. Sometimes all within a matter of an hour or two. Okay. So the scenarios. Back to this guy. COPD, same guy from the first part, except here we've got a magic pH change. So I think you could argue that this guy could be an appropriate candidate for non-invasive ventilation, even with accessory muscle use, even being diaphoretic, even looking bad. Non-invasive ventilation has been shown to help and keep them from getting intubated. So you try it, you do gas, you go check on him again. He still looks terrible, he's not breathing well, he says, I'm getting tired, I'm wearing out. So you're going to intubate him, and you're going to do what? What do you like? I'm not going to answer this one. AC mode, perfect. So we're going to put him on volume control. What do we want our FiO2 to be? 100%. What would like your tidal volume be? It's already written on your page. This one is going to say 10, but we're going to have a change here later on. So whoever is going to answer next is going to say 10 mils per kilo. And then a rate of 14, peak 5. You know, with this kind of obstructive airways and that kind of hypercapnia, though, 600 mil tidal volume, you're not going to be faulted for. It really isn't a wrong thing to do. And they used to ventilate. I was reading a paper from 1986, and they were ventilating patients in this study. It was a study with 22 mils per kilo. I mean, they're given literally like 2-liter tidal volumes. So you can't really go wrong. We see these numbers of 600 and 700 mils, and we all get nervous because we don't see those anymore. But outside of ARDS, this wouldn't be a completely inappropriate setting. I would lower it, but you really couldn't be faulted for initially setting that up. Okay, so you're going to monitor all of these things, obstructive airways, right? We're going to see high peak pressures. We're going to see probably relatively normal plateau pressures if we were to do a inspiratory hold. You're probably going to have some Autopeep, so you can adjust those as we've talked. Get an ABG. So this comes back on the settings that we chose. What's our problem?
Airway problem?
So you've got an airway problem. All right? Resistance is going to be high in the airways. Our peak pressures are 49. This is way too high. We got a difference here of larger than 5, but we've also got a plateau pressure, and it's greater than that magic 32 number. So we've got an Autopeep of 8. Our oxygen looks great. We've improved our CO2 a little bit, but our heart rate's really high and our blood pressure's low. So importantly, we have 8 Autopeep too. So what can we do to change that?
Just a quick question.
Yeah.
What is a normal peak pressure?
Normal peak pressure is going to depend a lot on your resistance in the airways. So everyone will have a little bit different. There's no magic number, but when you start getting really above 30 on even a peak pressure, you're probably have some degree of airway resistance. Probably normal plateau pressures are going to be around the neighborhood of 12 to 15, if not even a little bit lower. So your peak pressures are probably almost always going to be under 20. So I would highlight that we've put an obstructive airways disease patient with a respiratory rate of 18. I think this is probably our biggest problem. Gives us an inspiratory to expiratory ratio of 1 to 1.5. So we don't have a whole lot of time for exhalation. That's going to be contributing to higher pressures, probably the low blood pressure, the higher heart rate. Heart rate's going high just because he's trying to maintain perfusion with probably a decreased stroke volume. We're oxygenating like a champ. So this is not our problem. If anything, you can start to recruit normally poorly ventilated lungs because of the emphysema, and so you can actually worsen your VQ mismatch, and you can raise your CO2 from increasing your O2 too high in these chronically hypoxemic patients. So we have hypoventilation still, right? We've put them on a ventilator. We've still got a CO2 of 65. We have high peaks. We have high plateaus. We have Autopeep. We have hypotension. We have tachycardia. These were the ventilator settings we have. I think our rate was actually a little higher at 18, so we could decrease that rate down to 14. You can lower your tidal volume down 6 to 8 mils per kilo. You can decrease your FiO2. So these are all changes that would be reasonable to do. So kind of the big things for obstructive lung disease is allowing that expiratory time, making sure your Autopeep doesn't get out of control, and that's just allowing more time for exhalation. You want to ventilate them, but only to the point where you're not trying to normalize the pH. You're not trying to normalize the hypercarbia. You just want to get it better. And then you're giving bronchodilators and steroids, because if you don't do that, your problem isn't going to get better. So the ventilator is just support. It doesn't fix anything ever. Don't ever let anyone tell you a ventilator fixes things. It just buys you time to fix whatever went wrong. Okay, so case scenario number 2. This is going to be poor compliant lung. Previously we were talking about high airway resistance. Now we're talking about poor compliance or decreased compliance. So your 25-year-old goes out partying, drinks too much, gets found unresponsive. EMS intubates her in the field. They note a bunch of secretions and vomit in the airway when they're tubing her. Sats are 85 on 100%. What do you want to do? So you pretty much take obstructive airways disease and do the exact opposite. If you do 100% opposite, you'll probably be okay. So AC mode, I like AC, everyone uses it. Crank their oxygen up, keep it at 100. Tidal volume, okay. It is all right in ARDS to initially set your tidal volume at 8 mils per kilo. Caveat being that you want to try to work it down to 6. 6 is the magic, or at least we think 6 is the magic number. We're talking more and more about ultra low tidal volume ventilation, but 6 is good. You can't go wrong with 6. We do know that you have a 1.2 hazard ratio, meaning you are statistically more likely to generate harm for every mil per kilo above 6, increasing at 1.2 hazard ratio. So that bumps your hazard ratio up really high that you're going to induce harm for, and that's cumulative effect. Every mil per kilo above is an extra 1.2 hazard ratio. So you do want to get them down low as much as possible. We say it's okay to leave them at 8 mils per kilo because you're just trying to get them to sink. And then over the next hour or two, start to wean that tidal volume down. Because 6 mils per kilo is generally uncomfortable. We're not breathing 6 mils per kilo. We're breathing a lot higher. So this is not physiologic, and it's uncomfortable. And so you'll start to see them try to compensate and get into asynchrony. A rate of 14 and a PEEP of 5 there. So these are initial settings. So again, we're going to drop our tidal volumes down. Dropping our tidal volume down, what's that going to do to our minute ventilation, though? Going to decrease our minute ventilation, right? Tidal volume times respiratory rate. So we're decreasing our minute ventilation, so we're going to have to increase our respiratory rate. Again, this is not obstructive airways disease. So we're not having to fight all the resistance. We're having to worry about the compliance. And so bump your respiratory rate up, get your tidal volumes down, maintain your minute ventilation that way. And then PEEP is your friend in ARDS. So start to work your PEEP up. And there's ARDSNet PEEP tables. All you got to do is Google ARDSNet and PEEP, and they'll have the table right there. There's a low PEEP and there's a high PEEP. And it tells you if you're on this much oxygen, FiO2, you should be on this much PEEP. And those are good tables to follow. So how you monitor, same ways. This is what we got. 88% sat, peak pressures are high, but more importantly, our plateau pressures are high. And our difference between our peak and our plateau is pretty normal. So our problem is in the lung, right? Not in the tube, not in the airway, in the lung. Autopeep is 0. Respiratory rate's 18. There's our pH and our PCO2 and our O2. So what's the problem here? Our plateau pressure. This is the one glaring thing that just says this patient is going to walk out with concrete lung from ventilator-induced lung injury with that kind of plateau pressure. So what are the things we're going to do to try to get that plateau pressure down? So our oxygen is really pretty okay. I mean, if PO2 of 55 isn't great, but we're going to hold that. But our compliance is the problem. So the way that you really work on compliance and peak pressures, again, we're in volume mode of ventilation. So by adjusting our volume, we're going to adjust our pressure. Our pressure is the variable. We can work on I to E ratios. So we can start to draw that inspiratory time out, right? Give ourselves longer inspiratory times to deliver that tidal volume and work our tidal volumes down. And those would be the two best strategies, at least on the ventilator side. Get your tidal volume down and take out your inspiratory time at which you're allowed to give that tidal volume so that ideally your pressures can stay as low as possible. Paralyzed, prone, all that stuff comes in, but at least on the ventilator in the immediate setting. Your oxygen parameters are really affected by your FiO2 and your PEEP. To some degree, you get an effect from your tidal volume in the way that it affects your mean airway pressures. So we'll talk about changes. Hypoxemic respiratory failure, tidal volumes of 6, PEEP to improve oxygen, get your plateaus below 30. And more importantly, when you lower your tidal volume down to 380, you're not effectively ventilating. You have dead space of 150. So you're really delivering very little volume, which means you're not going to ventilate. So you're going to get hypercapnic, and that's okay. We allow hypercapnia so that we can keep our plateau pressures low. Actually, some research coming out now that suggests there may be a beneficial effect to hypercapnia. But that isn't completely clear. All right, and then the last part. Discontinuing mechanical ventilation. So, first, most important question, deciding whether you can come off of the ventilator, did you fix the problem? Why'd you intubate? Did you fix that? Because if you didn't, no point in trying to pull the tube out. So if the answer is yes there, then you go to the next question and say, are we on, quote, minimal ventilator settings? FiO2 of 40%, PEEP of 5, generally acceptable. With those ventilator settings, are they pretty normal in an acid-base setting? Meaning their CO2 at 90, and if it is 90, at least tell me that their pH is 7.39. Okay, some people live at 90, not very many. So do we have pretty acceptable gas parameters? And then are we hemodynamically stable? Meaning, you know, maybe they're on 40% FiO2 and a PEEP of 5, but they're on 30 mics Levothyr. Probably not the best idea to pull the tube on that patient. You know, and then are there other signs that they're just not doing well? So vitals are stable. You're not using a lot of invasive, terrible drugs. And then finally, the last question, do they breathe on their own? Are they awake? So did they get 8 milligrams of Ativan over the night shift? Just leave that there. All right. So then we decide that they're ready. They're ready to go. So what do? We put them in a spontaneous breathing trial. Here we call that CPAP trial. I don't care about terms. There's some people who are sticklers on it. but you're going to let them breathe on their own, and you're going to give them a little pressure support to help them breathe. Most of the time we do that with 5 of pressure support and a PEEP of 5, and that's the way we do it here. And we let them go for now 30 minutes. All the trials are done in 30 minutes. We used to do 2 hours. I don't know why. But anyways, you can do a 30-minute trial, and you want to look for, do they remain hemodynamically stable? So is their respiratory rate okay? Is it not 45? Because if it's 45, they're not ready. Is their heart rate 160? If it's 160, they're not ready. So do they remain hemodynamically stable on their spontaneous breathing trial? And if they make it that full 30 minutes without having to be put back on the ventilator, full support, then we get parameters for weaning. And that is the 2 most single important parameters, with, even if you want to take it down to a single parameter that is important, the rapid shallow breathing index, which is the frequency divided by the tidal volume, but the tidal volume's in liters. So if their tidal volume average is 480, it's the frequency, the respiratory rate, 22 divided by 0.48. So tidal volume in liters. And that magic number is 105. That's where the studies came from. If their rapid shallow breathing index is less than 105, they got a pretty good shot of being able to come off the ventilator. Now, you also want to pay attention to those other things, especially in some other types of conditions, neuromuscular disease. How much negative inspiratory force can they generate? We normally like to see a negative 20 there. What is their total vital capacity? I mean, when you get these vital capacities of 1,500, you can feel pretty confident that they can breathe okay. And then minute ventilations, but again, minute ventilation is really reflected in the rapid shallow breathing index to a large degree. So that's, you hit all your parameters, your rapid shallow breathing index is 45, you're good to go, you pull the tube, and they're free. And then 30 minutes later, they crash. And that happens. The rapid shallow breathing index predicted an 80% success rate. 20% failed. If you have a 100% success rate on extubation, you are too conservative. You should fail some of the time. That's okay. So it is not a absolute tuck your tail and walk away in shame if they fail. Because there are just some things you can't predict, and you have to give them that shot. And then when it comes to waveforms, this is what I still feel like when I look at waveforms, especially in tests. They pick weird stuff up, and I don't know what I'm looking at. All right. That's it. That was a long. All right. So I think we're going to get to play with the vent, but let's take a break for a little while, right? Bathroom breaks, walk around break, hopefully not smoke break.
There's restrooms just outside. That's behind us. The cameras are set up. Recording there and also report over here, but we can probably talk about
We can record it. I don't know how it's hard to see it.
and if it doesn't work out, we can always script the recording.
This is probably something.
Maybe I just didn't see it.
Yeah, well, I just don't see how it's going to be able to focus.
No, maybe I just didn't see it. Normally I look at it every day.
I mean, we can try it. I have no problem trying.
No, but let's do 5 in a row.
Simon, are you listening?
So
I just got my
I gathered
No, I don't.
Okay.
Oh, yeah. That's cool.
The optimal.
the last
I'm glad you know.
is what I've understood.
I can text her.
So much to do now, but
Sure.
yeah, I got it colored a few months back. But
okay.
I mean, we had Chad go in and teach 1 or 2. He won't, like, I guess we could ask him for the later ones, the summer ones. He won't do that. I haven't heard that in you, but I don't know if Jason or she would ever do
I just don't know if he had talked about it or if Kelly was just like, I was teaching her. Scout on me?
Yeah, I don't know.
Didn't call me.
I think she's mostly been the one that has been teaching them.
Maybe that's why no one's answering, because they're like, I'm not doing it.
No, I didn't see your email. What?
No, I'm not like that. I was just like, hey.
Yeah.
Okay.
Did she tell you like her setup for her security class?
I'm not saying,
No.
but no. Like, we can
Go over all that.
yeah, no. And so I was like, we were talking about something.
Yeah, and I saw my thing notified me that it brought up this T box, so that's why I didn't saw that.
No, like, we were talking about something this year, too, and I was looking at classes, like, there are like 7 classes this year, and I was like, who's teaching these classes? Not me. Well, okay.
Which I know, I don't know, Jason originally just to be the like representative for the rep. No idea. They were more concerned with like
Check the RTHK, see if there's a way that we can bypass, because there's no.
hookups.
Yeah, there's got to be a way to bypass.
I can do that.
He does just teach the machine. Like, he doesn't work here, so why would he teach how to chart?
Yeah. And so like everybody was reteach them how to chart. Really, you just do it. Yeah, we usually like to try to keep them with, we usually like to keep them one, they'll just have a CRT by themselves. And then usually
Where's test notes?
somebody who starts CRT, but we don't just say like, oh, it's CRT. We like to make sure that they get teach now. But, yeah, I've been Melissa just all said it, and I was like, yeah, no, I was glad you did that. Oh yeah, it's like I always bring them in the classroom. Like most of the time it's cold. Otherwise, I woke up really
I just sent in a request.
yeah.
Cody's going on to Plateau. So I want to like really great shoes. So it's a really good opportunity for us. Like it's like it's an amazing school. For this year and the next year, after that it'll be Australia. Which
You can touch them in the nose.
yeah, because Australia has a worse vacation visa. And you can go over and like all the way. I looked at the international traveling visa and get licensed.
Can't bypass it.
But
Just tell you what to do.
Yeah, and that's like why I want to. So we'll go visit him for a couple weeks.
Available, and I just sent in a request.
Yeah, I like messaged her last night. Is there like a list of them? Like, list of what's available already?
No, she just sent the dates, and so then I went to Chronos.
Oh, where's the date?
In the email, or
She just said like through this date, right?
yeah.
Okay, so she didn't list like actual dates.
No, she didn't. Right.
Okay. Oh, see, I didn't think so. It wasn't. Schedules. Yeah, she said like 13th of the night.
Oh my gosh, that's so cool. Good for her.
Yeah.
What is she doing?
Biofabrication and regenerative medicine masters.
What is it?
Biofabrication and regenerative medicine. Basically, it's like 3D printing a lot of stuff, and then you can restructure like proteins and stuff.
Camera 2. This camera 2.
Is that his master?
There's the camera 2. Copeland.
When did you graduate with his?
Microbiome. He's been doing research for the past couple of years, so it's really enough to do that. His life dreams to be a space doctor.
Nobody said that.
Literally, literally that's his dream.
There's
His home says like scientist astronaut.
podium PC, cameras,
That's
content,
his dream.
Shouldn't really make
document.
He wants to be every little kid's hero.
Not that. Room camera. There's different positions for that camera.
Is y'all's name's Jimmy?
What's your
My
name?
mom's
No, but everyone but Jody turned around.
I know,
Because I didn't hear you.
I don't know. I'm gonna email
Oh wait, which that's what it is. It fits into that one, and then we can just tilt it that way.
Are we supposed to get them all?
Sure.
The survey email?
Yeah, for
I never got it.
I haven't got it yet.
I have the certificate, so do I need to send it to you so I don't get payroll deducted?
Yes.
What area?
Advanced burn life.
Did they, how'd you get the certificate?
They gave me one while I was there.
Did you get one?
Because I thought that's how I was going to get it, is I had to do the survey.
They
and then
said
I
I
did
would
it.
get it when I did the survey.
Why would you get one?
But I'm pretty sure I have one because I was going through like all my stuff.
Did you get one this last time? Did you get one this last time? What did you get this last time?
You know, she went the day before me.
When I was there. I just can't remember.
Yeah, I didn't get one. They said we'd get it to look for an email, and that's why I've been looking
See,
for
I
an
didn't
email.
think I get it, but for some reason I was going through like all my stuff last night, and I thought I saw like updates on ADLS for 2018. I'm pretty sure I saw one. I'll like find it when I get home, but not on my email. Like I think I have a handwritten like a normal certificate that we get for, like one of those like contact and stuff.
I'll email.
I don't remember getting one of those.
I didn't remember until I found it last night because I was screwed because I'm moving, so I'm trying to organize stuff.
Let me know if you don't have it.
Okay, I will. Only if I don't. Yes.
How do you
Next
type
week.
then?
So we got paid last week. We got paid on the 3rd, so we get paid on the 17th.
So then,
So yeah, you already have a circle, but I don't know what
yeah,
your
but I
circle's
just
for.
want to see. So this is one page.
So the pay period will end here. Or no, the pay period would end, so for this one, it would end here.
Here.
No, you worked here in transport forever.
Yeah, I know.
So we worked together for way longer than that. So the pay period will end here, and they'll make the checks like here, and you can see your checks usually on like Monday or Tuesday.
Because I know they say that it's good to pick up only one check a pay period. Because the taxes.
Yeah, I think that's crap. I've heard, okay, so I've heard you're not supposed to do
Well,
It depends, because it's like you shouldn't pick up an incentive shift on the weekend because then you get paid too much. It changes your tax bracket. Blah blah blah.
if you're doing all the math to figure out your daily taxes, then you should just, I don't
Well,
know,
let me tell you,
quit and become an accountant.
I picked
With work.
I picked up an extra incentive on the floor on a weekend. Still got paid great.
Really?
Yeah. I
What do you
mean,
get incentives?
4 East, I was able to go over there, and then
How do you ask them?
I just call up and ask.
Do you have incentives?
Also, sometimes
They'll just ask you on an extra shift.
usually we'll send out an email, like, you need an email saying
Mhm.
where needs help.
GTU doesn't do it.
And also just,
You do get those, I just don't check the
no,
email.
I always don't email or check it so much. Also, GT says the no insurance.
Yeah, a lot of places are trying not to now. But still, extra on the floor is still pretty good money.
Okay, so this is a pay period. Yes.
So we're waiting for oxygen tanks. Apparently you can't run an event without an oxygen tank.
I picked up.
Probably not a bad idea. But we'll bring it, and then
It'll be
we'll
the Saturday
play
before
around.
the next check.
Okay.
So till then, just sitting. Oh wow, that's an oxygen tank.
Sorry, they hide them at the front of the hospital in the basement. It's nice to have RTs to help us out with these kind of things. This is not my area of expertise. An RT.
There's no RTs.
So I just this class.
Among other reasons. Because usually go to the bed.
Not gonna have a bell.
No, it's
Well, I don't know what's going on.
Yeah.
Saying this, I tried sectioning.
Yeah. The alarms are confusing. I don't silence them because I'm like, they're alarming for a reason. Maybe
Unless I know what it is, I don't. Only if I know why it's going on.
So when does the pay period start over? The day we get paid?
No, so you get paid here, so it starts here, so it starts over on Sunday and it'll go all the way into here. And then you'll get paid for this pay period right here. So you'll get paid for these two. Yeah.
Okay, so this, we got paid here, so the pay period starts over. Okay,
The pay period started over Saturday.
so we get paid here, the pay period started over Saturday. And then it goes until this.
You have to have a regulator bell.
So basically, it stops Saturday, so basically it's like these two, and then you get paid here. And then it'll be,
Oh, so it starts and stops Saturday, okay.
so like if you work Saturday night, it'll go through.
Can't you run the ventilator just on room air? Switch it to 21%?
Right.
That's what I was trying to do it, but it didn't seem to want to do that either.
There's no piece on here. RT worked last night. I was looking. I have to get the text it back.
You can tell I don't do this part.
Sorry for the text.
I wasn't the person that's before. I'm so sorry.
What's up, guys?
I don't think I know what that is.
Are you calling somebody? If you want me to ask.
I'm texting and calling Sherry the educator.
Isn't that what No, it's in that Wells Fargo building.
Oh, it's not places like, isn't that like fancy? I have to have a reservation. Remember on the street? I did.
You got another contact. Sherry worked last night. She's been texting me back, and I don't know if she knows.
Robert. I don't have his number.
I don't have anyone with Sherry unless I call the unit for the charge. RT. See if they do.
Why is there a dot on the screen?
Who's charging?
Create extra. Michelle.
Fourth of Frankfurt, more or less.
And it's a house.
What is this room?
Not too far from work. It's not available to all girls. He's in June. I'm gonna move in with Cody, but probably just but I was wondering what you put over there until August. I like how you spelled your name, but it wasn't like he doesn't know. He thinks it's already. It's just he lived in that house for like 2 years without a lease at all. It just they know the landlady and whatnot, and he thinks like I'm pretty sure my lease already ended again, but I'm not sure. It's like I need to find somebody to take over my room.
So what class is that?
No, I'm not working. I'm like, I don't want to hate me. Because like there's only like one person that I know that can make or they she. I'm pretty sure he was little and very happy.
Yeah.
Maybe it's not mine. Yes. Yeah. I don't know what kind of that was. Because it says it's not even loaded yet. I put her in my phone. No, look, it's right here.
Well, it's not right on your stamp.
I can't control that. Yeah, you can.
Look at text for anyway.
So this one, they did one last time, but they didn't. The fix there. So last year they
We did. Yeah. We're actually trying to do some of that right now. It's moving, like literally. That's fine. Yeah, my parents were there 3 days, there's 4.
Yeah.
Let's see. I might talk to his phone, but highly unlikely. Especially with like, if you want to consult usually, if it's a sick kid, yeah. Like it's just a small burn kill now, but if it's a big kid, yeah. Big burn.
From that floor, about an hour.
I feel like anytime you talk to Carmen, it's Pete say.
At nighttime, yes.
Yeah.
Have you touched a piece? No. It's all of our big ones. It's like if it's a gym, it's like healthy enough to frequently enough that some down. Christine's a bit better about rounding. Michael does too. I feel like if y'all are really confident and we're having a whatever night, it doesn't really matter. We don't need to go over there. We'll just call them. Hey, about this, this, this. Yes, okay. So it's like the best, you know. Are you hard to reach like y'all know. We gotta talk to us. You know, around if y'all need anything. Alright, let's go. I'm gonna go around.
That in the air, which does, but then like the shoe pushes it and pulls it.
Depending on the mid-level or the intern, they'll come over and usually try to write their notes over there. She likes to come over to Vern usually.
Yes.
Tomorrow, like, today,
Always interrupt you.
Yeah.
Okay.
I just want to write notes out.
Okay.
yeah, it's okay, let's do that tonight.
It doesn't matter. You can tell me what you like.
What?
It doesn't matter. Do you want me to do it?
Where's the safe haven?
Okay.
Like, sorry.
Do you know the name by any chance?
It's always too much, especially the last 2 months.
It's gotten good this year.
Yeah, I think we only have 2 months open.
Okay, we'll do it.
Finally.
15, 20. Thank you.
Because I saw on the teams that they were like thanking some SF nurses for going over there because they just love.
Dang.
Yeah.
Right.
I know we all have like a group Snapchat.
Oh, that's fun.
And I heard texting one night, and we were like, yeah, so Indiana got really busy. It was crazy. She should show us what it was. They're like, yeah, we had like 3 big cases. Like, I'm in Mexico. No, just coffee from Lauren. I know, whenever they give it to me, I was like, you were this secret? Okay.
So you guys have
Last time I
Let's
crashed my head because I was using the shit for like 8 o'clock. All of a sudden, I had like line here, probably like 7. I read.
Yeah, like they have
7 a.m.
be like,
No,
What is it?
at 8 p.m. and like they're like 7 hours prior coming in. And I was like,
so they have to discharge them.
no. It should have only been 3.
Yeah.
And like,
Because you
two
can't
days,
take
3
3
hours.
yards
So
back.
still decently busy, but I was like,
The only time we were able to do that was
That one guy.
we're never gonna do this stuff.
No, it just keeps.
Never happened. Pretty much every night. Oh no, it's fine. Never traffic out of there. It's not really me. You know, I can see your nurses, but yeah, it's just whenever I'm over there and I'm just like, just taking pictures. Not mine, not mine. I'm so sorry. Not mine.
Yeah. She just like, he's been in neuro for or he was just talking and she's talking about stuff.
Oh yeah, they
I'm
won't.
sure he's in a while. He won't take it so much.
No, he was over. I was over there.
She'll start like, who has room for somebody lady?
And
In the board. And then the last 4 weeks, like, just
he like was kind of
oh,
by
you
the
guys keep saying that. Well, probably for a reason.
boring.
So you know and so we know. Like, organized.
I think I'm ready to come
But and you
home.
can't. I'm good at something. I know. I'm like.
Ready to come home.
Yeah, first thing I
The other day you had that person in your
Yeah.
mom that was like having a camping. He's like, but I'm eating.
Yeah.
Oh,
I
yeah,
didn't
yeah.
really do that about Sierra.
Patient is room 3 and like he kept coming out talking to us about his
So now we have
He's a oncologist at
part-time,
Copeland, and
so
so
Curtis.
and Dr. Campy was like,
John,
why he's
he's
talking
in
to
John,
him
John,
because
got it.
and you know he's got no background, he understands what come out because he
Because
is
we had
And then he just comes
Because y'all have
oh,
Sam.
oh, you're lactic. Oh,
Jen.
Yeah. For a minute, yeah, and then and layered.
So we're like,
Layered,
yeah,
layered,
y'all have
layered,
to
Sam, and then
like, no, but
So
it has
it
to
was
be.
just-
You got old. So his brother kept coming up like, oh, he's crazy yelling. He's yelling at us. He's like, no,
We just
have
had
to be.
just
So
Jeannie and Amanda for a while. Once Karina went to days, and then Amanda went, and they were like, we'll be another one. And
I like him, I just don't like his.
Kayla came in a couple times.
And every family has
There's like, and then on the full workup, at least for Christmas, they're all in whatever.
Why?
Like Christmas,
There was no answer. She was giving everybody the romance. Like, oh my gosh, we got a patient from her the other day. What was she? Gave me something.
She did pregnancy test?
Yes. I was like,
You never know.
oh my gosh, you died laughing. She
ridiculous.
laughing.
We had a guy that came out for the pregnancy test the other day.
You know
I was like, was that on purpose? Like,
put one on
some man last week. It wasn't for that. She laughed and she's like, oh, you can never be too thorough. And I was like, yes, you can.
Like
something. Actually,
Either
yeah, we laughed about it.
and he came up to MI.
She's from like the Martian
Monitors anyway. Why? They're looking for stuff and I was like, what? I get shot all the time. They don't monitor my airway. They should. We had one that she used to come all the time. Random things in there.
That was a good one.
A coffee cup one time. Like a little on coffee cup.
I will appreciate that joke.
One day. Once she came, I think it was, I don't know if it was the same one, but we had one that came in and she was like she was asking me about I mean,
Like they are.
Yeah.
So med-surg to get sorted. I know I had to call them the last 2 days and they floated as their floor nurse to ICU.
That's funny, because I was on call all day yesterday.
Had 3. And yesterday, it's
I really don't. I think
That's two babies.
unless they have
Two
two
babies.
babies.
Two moms.
Like, you know, like I guess they used to have like.
She doesn't know now.
After they had
Not for us. She's like, I'm not sure how it works with you all.
What killed now?
She's
I
not
was
sure.
wired.
I've been trying to get
I
this
barely
bill covered by my insurances because
And now you
I
can
have 3 insurances. I've been trying to see how they're extending it this covered. So I've just decided to screw it and pay it.
How many insurances do you have?
2.
We were scheduled
Yeah, no,
to.
you're still.
My dad and I. I've already told that vision, but on
They do that so they can do that big PTO.
So they'll be bringing it soon.
My mom's
If y'all want to discuss anything related to
Yeah, some do.
lung and or critical care while we're waiting, happy to talk about anything y'all have questions over.
BRBC.
PRVC? All right.
BRBC.
So PRVC is a hybrid mode of ventilation. And it is standing for pressure regulated volume control. So what this does is it combines both aspects of ventilation with, or both parts of, the good parts of both AC and pressure control into a single mode. And what that does is that the problem with volume control is that you have preset flow. So you have your flow pattern either as in a ramp, ramp or decelerating where you go up and you fall down in a fashion there. So this is fixed flow. And the problem with fixed flow is we don't really breathe through fixed flow. We breathe with variable flow. And pressure control gives you variable flow by giving you your set inspiratory pressure, but the patient gets to inhale with whatever vigor they want up to that pressure. And so getting that flow rate customized to the patient is really nice, and it makes them feel better, like they're not having to breathe against a vent that won't give them what they want. And so with PRVC, you start as pressure, and you so you get that variable flow to start with. And what it does is it will finish that initial inspiratory flow setting and then read back how much volume has been delivered. Depending upon how much volume you've gotten, it will then give the next amount that's needed to reach that volume as additional volume. So then it switches essentially over into volume control, making sure that you get that tidal volume. And then the ventilator is just constantly cycling back and reading those numbers and trying to adjust itself so that it keeps a good pressure and volume setting. So it gives you that initial nice flow, which is important, so patients feel comfortable on it. Some of the pitfalls that you can get on, though, and this is why it can be potentially overused, is let's say you have ARDS with decreased compliance. They get that initial flow in, isn't even close to delivering the tidal volume you want it to deliver, pushes in the additional volume that you need. Now you've got pressures that are in the high 30s and 40s. It's going to try to cycle and adjust and do things so that it doesn't have to do that, but it can be a lot higher than you would expect, and you can get some dysregulation. So it isn't as controlled with me just putting settings in and knowing what I'm doing. So I don't have a problem with it. Again, I don't have a problem with any mode of ventilation. Just have to kind of recognize some of the pitfalls with it and be cognizant so that you don't run into trouble. There's a lot of really good literature coming out now on driving pressure, which is the inspiratory or plateau pressure minus your PEEP. We're finding that there's really big cutoffs in survival, or what seems to be survival benefit from driving pressures less than 50. There you go.
Appreciate you going to us, sir.
Make sure to plug out on the
Thank you. Appreciate it. Y'all need this back? I think this is
You can
one.
choose to have dental and health about
Thank you.
And so it came to another side, I was like, oh, perfect, I'll just get health insurance. Or not, I was like, I'll just get dental. Because it was health insurance. Yeah, I guess. It was like, well, screw it. I can't do it. I'll just take the yeah. It's just really annoying. And then at one point, you know, I'm really smart for insurances because I have insured whenever I was transport and boarding line. So I had through here, and I had through my mom, and then I had two through my dad because I had TRICARE and another one. That was a nightmare to manage. That's like part of the reason why like I couldn't do that bill pay for forever because I had too many insurances and nobody was like, I'm not primary. I'm not primary. No. You are the primary at that point. Yeah.
So you see very, 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 like my dad was supposed to be second. I went to so that's not gonna
be a problem. It's the commitment issues. I don't know.
Oh, we don't
So the easiest thing will be to everyone come crowd up and familiar with each other. We're gonna play.
This is so this is nice.
Alright. Now this one, I don't really think that's true. It's just straight and see. So I can't really show you the respiratory pause. But what we can do is start just have see. Set these up. So standard buttons, you hit something until it turns the color, and then you play with it until you're happy, and then you hit it again. That's where I got it. So let's take a go ahead and do like an obstructive airways problem, and take a otherwise healthy asthmatic comes in, makes sure and gets tubed. So who would like to set up the vent for him, and we can even go into. Okay. So who wants to set them up? Stay here. So they volunteers themselves. I'm going to hold this thing. Okay. Go for it. What's that? Oh, that's okay. Let me try to get out of this.
Just sit it up to that.
Yeah, that's it. You get to play. You get to do whatever you like. That's what I said. You just hit it until it turns a color, and then change it, and then unhit it again. It'll turn off color. There you go, and now you can hit another one. Okay? Just that. He does that. He does that just so that he knows that no one else has touched his vent.
We were trying to figure out his reasons behind that.
That's exactly what
Well, we appreciate you telling us his reasons.
So you're actually in pressure here. So we're going to explode this now.
Oh, okay.
Let's
I only know PRBC mode.
So
We only use PRBC.
APV is going to be AC mode. APV SIMD is kind of your SIMD. You've got pressure, and then you've got spontaneous. And those are really all you need to worry about for this. Right? You can even use APV SIMD. Just do SIMD, APV, CMD, and then spontaneous. So those it'll give you, and then if you want pressure scheme. So that's AC mode, pressure mode, SIMD, and spontaneous, which is pressure support. So those will be the 4 you can get. All the other ones are fancy. So.
I think with this machine on our floor, we do the
The SI uses APBS. Yeah. We use CMD, which is just pressure, volume control. If you want, you can select whichever one you want. You want to use pressure, you can use pressure. Okay, pressure. So now this is where you're going to do the initial setup. And all your buttons, however you want to do it. Whatever you want.
I said 41. 41%. Oh, was it 41%? Okay.
I don't know. Well, I asked him, because that's what I wanted. That's a helpful answer.
Yes.
So you've got a P-Hive 35, and we're getting tidal volumes of 42. So we're getting unit ventilation. How do you want to fix it? Split it in order. So in pressure control, your peak inspiratory pressure you set is going to be your plateau pressure, right? Because you don't have the peak. You're setting a ramp up to a set pressure. You're holding that pressure for the time that you tell it to. You're telling it to based upon control here. So here's your T inspiratory time. So you're holding them at a P-Hive 35 for 1.3 seconds.
So would you want to increase your inspiratory time?
You could. You could increase your inspiratory time, but you're not changing the pressure by doing it. You may give them a little bit longer time for your volume. It's also not getting everything back. That's pretty bad. It's trying to deliver short successive breaths because it's not in the telephone. I'm trying to make it where it's not going to do that so much. So that's what we're working on.
So what happens when we change the pressure?
Well, that's what you can find out.
Do you have to like cook it again to actually set it?
Probably not gonna let you do that because it's trying to save you from killing.
So, go down.
So what are you reading? Now you've got good tidal volumes of 760. Pretty good, right? So now, I'm just going to go and see what this first. What else I think it's going to do? I think it's supposed to change the resistance by moving this way. She changed the resistance. Oh, yeah, now we're in the resistance change. Okay, so what are some of our problems in our numbers there? What's our pressure? Okay, so is that a problem?
Lower.
Lower. So, what do you want to do? You can always change your mode. What's your other problem? Just looking at the stuff we talked about. What do you see?
Your flow on your inspiratory, your flow is
That's right. We've got a huge amount. Disconnected. We set them back in now. Fine. Now, you got a lot of different settings. So this is just your backup rate. So it means if he quits breathing altogether, it's going to go into that. So you don't have to really worry about that because we're not going to make it. This is what I mean by you now are going into volume control. So you're going to have a flow wave flow pattern. A ramp pattern, or you're going to have a deceleration. That's decelerating. That's that's your. So you either go with that one or that one. Okay. Square? Square wave.
Yeah, that one.
Alright, so we're going square wave, flow. What else do we want to say? Don't worry about ramps, don't worry about these. So you can say it's short time, it's just going to be flow rate. So longer, or the shorter inspiratory time, the longer expiratory time you're going to have to rest. Okay, so you can set your flow time.
do one. I was like, you're the wrong person to do this. Well,
Alright,
making
good.
it in my mind.
You don't have to worry about a inspiratory pause. That will actually only be bad. This is your pressure support. So this is important. This every non-mandatory breath, you're going to support him with the pressure. So you pick your pressure you want to set him with. Up to you. Alright. Now, how many breaths per minute? Okay. And set your time line. So let's say he's 80 kilos. And that's ideal.
So say will be 480.
Yeah.
Now to confirm.
No, it's not breathing. That is not the way for wake up.
Let's see if I just let you. Okay, so in these settings, you've got a breath rate of 14. So you're feeling at 14. That hasn't changed at all. You've got a peak pressure of 41, and out of the 480 that you're trying to deliver, you're getting 70. Oh. And essentially what's happening is you're just doing pressure regulation. So you're trying to deliver that tidal line, because pressure's so high, and you're sticking.
So if we go down.
Keep pressure.
Oh,
For the components.
79. The one where you held it down worked really well.
Yeah.
You're doing great. You got this. Got a whole 20 people in here. You got this.
So how do you change the
Peak pressure.
expiratory minute volume flow also?
So that's where you have to go back to how are we going to fix what we're trying to do. So there are the ways that we can work around obstructive airway disease.
You can lower the volume and lower the pressure.
Blue volume. Yeah.
And then if we have pressure on the other one,
One is a big principles for this. So lower the volume. What else do you want to do? So just try to get his pressure.
maybe increase it.
So if you want to give the volume over a longer period of time, or a shorter period of time.
Sure.
So let's say half second.
And then go back to the short.
If we decrease the rate,
A longer period of time.
Try knowing that when you do that, you're going to do worse in your IEU ratio.
Yeah. And then running your ears really great.
But what's your measure to know whether that's a problem for you?
What's your measurement? Gotcha.
What are you going to look for to find out whether that's a problem? So, are you breast stacking? Do you have a, does your flow return to volume? Or does your flow return to baseline flow? Here it does. So it's at 0 before that breath kicks in. So you've got actually good to work. But you absolutely can decrease. Now we're getting pretty close. Peak pressures are high. So, but we're getting our volumes. We'll read it around. We're trying to do. Yeah, let me get that exhale time. So now we can actually start to look at that. Let's see what happens. You're going to forget peak from that. No, you're just not perfect.
So you're judging how you would adjust the inspiratory time based on the flow that is going back to baseline. So you're saying how to.
So even if you wanted to take it out, this is not accurate. So look at that inspiratory time. 4 seconds inspiratory time. Does it return to baseline? You may not.
Not really comfortable.
Can you imagine getting forced air for 4 seconds? It's going to be uncomfortable. But at least from a waveform standpoint, maybe it's paralyzed. So, it's resistance, that's right. Let's see what happens. Increases resistance, and we'll see what happens to the changes. So what happens to the waveforms? As they roll, so our pressure dramatically shifting up. So it's trying to deliver that tidal volume. It's running out of time, so it's pushing that in. Go to really high resistance, we can see what happens. So this is really resistant. easy you have bound restrictions. Just trying to deliver that volume state. It's got a lot of time to do it in, so it's able to sit there and deliver it over a longer period of time without the resistance. Problem if you really have a restricted lung disease, you have to allow for exhale time. Normally, you're going to have resistance coming from the other organs. So it's really just kind of giving this resistance. It's not really how the problems are. So you can see something more like this. This is what I can show you. I was talking about your volumes. It's not reading that it's getting the volume out. That just drops there. That's what we want to show you when you have a problem with not getting all your volumes. So either there you have the leak, somewhere. So it'll always reset this. The initiation. That's what I was trying to do. Okay, so that's that. Now, when we put springs on and do the other side, this will work. All right. So now we should have order compliant. So let's go back to settings. All right, so we would like to try to set up for ARDS. So here we're going to have decreased compliance. All right.
Okay.
Okay, so we're going to basically body control with SM.
Yep.
Okay.
No guidance. Okay. Just never really want to do it. Perfect. Okay. So I feel like we need something we can put volume in it, so not low volume. No. Okay, so I know we don't want our volume very high. Do we know how to
So we're 70 kilos.
Okay. I'm not anyway. And then you don't want the pressure very high. Okay.
Okay. So 10 breaths a minute, 420, 5. They're at hypoxia.
Yeah.
Now you're on FIC.
Okay.
Okay. So we go with Google searching, ARDS, net, PEEP, table. PDF. First hitting Google. So you have low PEEP and high PEEP. So you're on 90%. How much PEEP do you want? Low PEEP here. So you're going to go low PEEP straight.
Yeah.
There was really no difference in low PEEP versus high PEEP in the trials, except for very severe ARDS with PaO2 FiO2 ratio less than 150. High PEEP group did that, only in that study.
I need to change something. Okay. So, I feel like this. Okay.
So read, rather than saying it sounds terrible, read the bill there and see what's doing.
Okay. So,
Remember, it's sounding like that because you got a key at 16.
we're like really sitting right here. Like, so there was room to work right there on the inspiratory side. Increased it. Yeah. Only for a little bit. Come back to the others for shorter period.
So what is your Plateau pressure?
30.
So are you okay with that? Just kind of quit reading what the volumes.
Okay. I'm okay with it, but it could be better if it could be lower. But these are supposed to be low. So it's just going to come down on pressures. So come down on the pressure.
Peak, well, so you're in volume control. So how do you adjust peak pressure?
Adjust the arm. Are they inverse relationship or they're like the same?
So if you go down on volume, we go. Sure. A few seconds to figure it out. It's supposed to be. Not that we're just going to forget numbers and act like it's doing what it's supposed to do. So no, that's okay. Your pressure will go. So keep it right. Lower tidal volume, you can fully refine one, you can take things much more time out. Gives you more time to deliver it. Because you're not fighting the airway resistance. Airway resistance is when you really allow that full long extraction time. So the RBS, your airways are never really a problem. So you can have respiratory rates of 24 because you have to maintain the information. So you drop your tidal volume so low, you create a respiratory rate to maintain.
And so that's why.
So you could go